we again move to other patterns of diffuse hypomyelination. If there is selective sparing of the white matter, these are pole 3 related hypomyelitic leukodystrophies. If no, then if we should look at whether there is hypointense thalami. If hypointense thalami is present, then again that algorithm look at the basal ganglia, and depending upon different involvement, different differentials can be put. And if again no, then look at the cerebellum. Then as we saw as we discussed previously, in case of cerebellar atrophy, look for presence of calcifications, and along with the atrophy or presence of calcifications or not, or presence of any certain specific clinical features, we can reach to a diagnosis. If nothing of these is present, look for any spinal cord involvement. It may be HPSL. If still it is not present, look for NA like peak. It can be Salas disease. If no, then there can be certain clinical clues, for example, Hertzsprung disease or inner ear anomalies, which can be uh, PCWH. And then if no, then look for, in the end, look for brainstem involvement. If only the ventral dorsal brainstem is involved and ventral brainstem is not involved, except for the corticospinal tract, then it is PMD. And if only ventral brainstem is also involved, the brainstem, that is PMLD. So this is a very complex algorithm, but while you are reporting, you can keep this algorithm with you and try to fit in each so that you can reach to a diagnosis. Let's answer what was the case of hydrocephalus. That was Aicardi-Goutieres syndrome. I think you're talking about this case. So this was Aicardi-Goutieres. This is the case of Torch, and this is a case of Menkes disease. So we have discussed about hypomyelitic leukodystrophies, and we discussed about demyelitic leukodystrophies in the last lecture. So MR plays a very important role in evaluation of leukodystrophies, and a unified approach, including both clinical clues and MR features, can help us in improved understanding of these important disorders. There is a definite overlap present. So whenever a case comes first to us, we'll definitely not give one diagnosis. But if there are certain specific features, for example, 4H syndrome, along with hypomyelination, and the patient has variants of uncertain significance or negative genetics, then we can tell that this is a very specific diagnosis, and we can provide a clue towards the diagnosis. Then there are a lot of emerging therapies, especially for PMD and certain other disorders as well. So in such situations, advanced MR techniques hold promise that they can help in quantification of the myelin, like amount of myelin, and can guide about the prognosis of like how the treatment is going. So before ending, I know it was a very difficult cases, and we may not encounter them very commonly, but I want you to take at least some patterns from this lecture. So we'll again have a very quick revision of the cases which we already saw, and I hope that you all will answer. So what is this diagnosis? We see diffuse hypomyelination with involvement of the dorsal brainstem and sparing of the ventral brainstem except for the corticospinal tract. So the diagnosis is, yes, so it is PMD. Very good. So we see the involvement of the brainstem except for the ventral brainstem, and only in which the corticospinal tract is involved. Then we have the other case where we have diffuse hypomyelination, involvement of both ventral and dorsal brainstem. So this is PMLD. Very good. So now you are answering very quickly. So this is a case of PMLD. So yes. So this is a case which you should always remember. Diffuse hypomyelination, certain white matter structures, the optic radiations. Yes, 4H syndrome is a syndrome associated with it, but it is a polar related leukodystrophy. Actually, my question was what will be the clinical features, a specific clinical feature which can be seen with it, and you have already answered. It is 4H syndrome. Then this is a pattern in which only certain structures are involved, like there is no diffuse hypomyelination, there is trilaminar pattern. This is not a Salas disease, but here only, yes, very good. Here only the early myelinating structures are involved. So this is HEMS, that is hypomyelination of early myelinating structures. Remember the trilaminar appearance of the posterior limb of internal capsule in this case. Then this is a case where we have cataracts, we have diffuse hypomyelination, and more conspicuous hyperintensities in periventricular white matter. So this is a case of, as the name suggests, yes, hypomyelination with congenital cataract. Then this is a case which you should remember, this pattern you should remember. So it is a secondary hypomyelitic leukodystrophy where we have diffuse hypomyelination but hyperintense basal ganglia and preserved corpus callosum. So this is a case of, yes, very good. So infantile onset GM1, GM2 gangliosidosis. So this is another case where there is diffuse hypomyelination with atrophy of basal ganglia and cerebellum. So it is, yes, very good. So it is HABC. So the other pattern where we have hypointense basal ganglia with skeletal abnormalities, along with that, we can have a lot of skin abnormalities as well. So this is a case of, yes, fucosidosis. And then we have cocaine syndrome where we have diffuse hypomyelination along with calcifications. And so this was the last case which I wanted to show you. This is cocaine syndrome, and we have differences like Aicardi Goutier's and Torch infections. So these were the patterns, and of all these patterns, please remember PMD, PMLD, Polar 3, and along with that, infantile onset GM1, GM2 gangliosidosis. So thank you very much. So these are my references. And I thank Ref for giving me this opportunity. Ref is wonderful. And right from my PG days, I have been using it as a very useful source for learning. And I know you all are using it too. And it is so useful for all of you as well as all of us. And I want to thank my mentors, Dr. Bijoy Thomas sir, Dr. Soumya ma'am, and Dr. Keshav sir for helping me with this presentation, as well as my mentor from AIMS Jodhpur, Dr. Sarbesh sir, and my friends from my department who have helped me with this as well as the previous presentation. And thank you very much. So the references, like this is one of our article. Then this was the adult leukodystrophies from radiographics. And this is another very important article, solving the hypomyelination conundrum. So this is again a very prominent article, and you can read this article as well. So these are the references, and thank you very much for your very nice participation. Thank you.
Thank you, Dr. Smiley. Thank you. I think you have simplified it well, and all the thank you messages are just trying to show that only. So it literally scares all of us out. So you have tried to make it as simple as possible. Algorithm approach and everything was really helpful. So we'll have you back with some other topic. Thank you so much for covering this difficult topic.
Thank you so much, ma'am. Thank you for giving me this opportunity. Thank you, ma'am.
Well deserved.
And thank you everyone for your very nice participation. Thank you.
Thank you everyone. Take care. Have a good weekend. See you guys tomorrow.
Record.